That's okay. Good stuff. Good. Okay, that's grand. I'll just very briefly introduce myself. Taaffe is my name. My role is as General Practice Nursing Coordinator for Cavan, Donegal, Leitrim, Monaghan and Sligo. And my background is predominantly in general practice. I worked in a busy urban multiple GP practice and then a rural Gaeltacht single GP practice. And I've been in this role with the HSE for almost 2 decades now. And I'm the nursing representative, or one of the nursing representatives on our Quality and Patient Safety Committee. So I'm going to give a very brief overview of what prescribing is, and apologies if many of you will know this, but it's sort of important because all of this kind of feeds into the safety aspect of prescribing and how we move forward. So these are NMBI's explanations of it. It's an expanded nursing and midwifery role, and essentially they're saying that any nurse who's in a prescribing role will be a nurse with many years of experience and skills and competency and knowledge that's way beyond that of any nurse at the point of registration. And the Nursing and Midwifery Board of Ireland, or ABA as they were then, were mandated to provide a framework to ensure that nurse and midwifery prescribing is safe. So the legislation came about with us. Minister Mary Harney in 2006 approved an application for a change to the legislation in order that there could be a legal basis for nurses to prescribe. And in 2007 that was signed into law, and NMBI were also asked to create a regulatory framework in order that we would have a structure that would support safe practice. So many changes to the nurses' rules and midwives' rules later. And there was at that time also in 2007 the creation of a new division on NMBI's register in order to capture the nurse prescribers who were eligible to be registered. So that means that nurses and midwives can now have the same prescriptive authority as doctors, vets and dentists, but obviously with quite a number of steps to go through before that. And there are 2 types of prescribing for nurses: medicinal product and ionising radiation, and obviously many GPs and vets have both. That's the summary of the legislation, which is that the nurse or midwife must be employed in a healthcare setting, and that can be any hospital, can be a GP practice, a clinic, a prison, public or private, but they must be legitimately employed. So you really just can't put a sign up outside the door and say, I'm a prescriber, come on ahead. The product is one that must be given in the usual course of the service that's provided by that nurse and midwife. So in other words, there's not for all nurses and midwives the possibility or the opportunity to just prescribe anything. It has to be within scope. And then there are separate provisions, which I'm not going to, but you can check for exempt medicinal product and off-label prescribing, and usually those will require cooperation and collaboration locally. And as with all prescribers, the registration number, your personal PIN number must be stated on every prescription. So in order to become a nurse prescriber, NMBI engaged with our higher education institutes, and there's quite a list of them now, that provide a 6-month part-time professional certificate in nursing and midwifery. The key point, and this has been learned with time, because certainly in the early days, I think there was a huge rush from services to have prescribers on site, and very often no service need. So it's very important to ensure that there's a service need, that there's the support of the employer, and that's all the way through, because it's quite an arduous programme to undertake, very involved, and it does require that there's an acceptance back at base, really, and in the clinical setting, that there is an individual there who is a nurse or a midwife who's going to have prescriptive authority, and the supports need to be there. And it's important to put them there from the beginning. So prescribing site coordinator role will see the nurse through the programme and hopefully just smooth out any barriers or issues that are there. It's important to have a dedicated medical mentor, and that's irrespective of your clinical grade or your area of practice, because that support throughout the programme especially is very important, just because of the nature of it, OSCEs and what have you. Upon successful completion of that programme, the candidate will register with NBI, who will confirm with the Education Institute that this candidate has actually completed the programme and successfully passed it. There's some paperwork, a validation form and a fit and proper person form, which is new. It hadn't really come across that very much, but that's new. And it's important to note that any advanced nurse practitioner, especially, must also be a prescriber in order to register. It's not possible to be an ANP or an advanced midwife practitioner without having prescriptive authority. So it does prepare the nurse and midwife for those specialist roles. These numbers are NMBIs from this year, from the stage of the register. And at the moment, we have 1,945 nurses who successfully completed the programme and registered with NMBI. Now, more may have completed but never registered. 588 are not practising for various reasons. Some of that, when we come to it, might have been issues with support. There may never have been a need for their prescribing in their clinical setting in the first place. They may have moved on to another setting where there isn't a need. About 10% of prescribers are male, the remainder female, and 1,154 patient facing. So there's about 99 who have prescriptive authority and are renewing that registration, not using it. And the age profile is as young as 25 all the way up to 65. And this is really, I suppose, the crux of how you make this happen and how you make it safe back at base. Things have changed a lot in the 15 years since nurse prescribing was first introduced. Clinical governance used to be really mandated by NMBI, and a very strict process for how you proceeded locally, and that changed in 2018. And the basis of the foundation for that governance was the collaborative practice agreement. But there were huge difficulties. The collaborative practice agreement, many of you are using it, and I think that's a great thing. It's a three-part document, part A being a profile of the prescriber, their clinical setting, the cohort for whom they propose to prescribe, and it includes scope. And because patients are patients of either a GP, if you're in the community, or a consultant, if you're in integrated care or in the hospital, the support of that line, I mean, governments ultimately rest for the patient care with that clinician. Support along that line was essential. That wasn't always forthcoming. Access to drugs and therapeutics was difficult. So NMBI decided, following quite an extensive review with the ONMSD in 2018, to remove the need for the CPA. There's no legal basis for it, and the situation now is that governance is local and there are many different approaches. If you ask what I think is best, I think at all times use the CPA. The final sign-off part of it isn't essential anymore, but it's a very good document that was well developed, very thoroughly thought through, and really lines out your position and your scope, especially very clearly, and with the audit and review and monitoring process at the end of it. Now, I know that in some areas it varies from there being no list at all. I mean, nurse prescribers are prescribing within their specialism, which is great and it's perfect. In other areas, a list is maintained and that's it, which is good, because if a drug alert or review happens, it's good to know, for a manager in the absence of maybe the prescriber in that particular day or for a while, what's been prescribed. But I do think that the CPA is a good document. And I spoke with an advanced nurse practitioner in an integrated care role, and she said it was very satisfying when HICWA came and knocked on their unit door one morning to be able to open a file and present all of those documents to CPA and have it all there and together. There was no explaining to do, there was no rationalising of anything. It was there because the CPA is that robust, sound document. So I mean, I'm probably overselling it now, but I really am very much in favour of it. It's very important locally to appoint a named individual with overall responsibility, be that your director of nursing, midwifery, public health nursing, or they may appoint an assistant director to assume that role. Hugely important is that you have a medical practitioner, a pharmacist, that you have access to both, because many times, and we've heard so many great presentations today about all of the many things that can change on a daily basis in terms of in dealing with medicines, and particularly in prescribing and dispensing them. And at all times, I know even as a practitioner, and I was never an advanced nurse practitioner or a prescriber in general practice, but on a daily basis, our relationship with our local pharmacists was invaluable. So try and, have that established and nurture and maintain that as you go along. NMBI still require that you have a medicinal product prescribing policy. That's something you don't need to go out and create. You will know this. There is a national one. There's one for the acute sector and kind of maybe hospital, or as I call them, four-wall settings. And there was another device for community settings. Take those and adapt them to suit you, or you can prescribe, with the use of PPPGs. A process for audit and review is essential, and this recently seems to be just from talk, it's come down very much to peer review. Colleagues are reviewing each other. There are many variations on what is used. Any audit or review must be based on standards, and in respect of nurse prescribing, that's the practice standards that I'll come to now soon, that NMBI have decreed. And I would say if you're not using it or you're not familiar with it, the Medications Appropriateness Index is an invaluable document. It's a good one. It covers everything. It's about just a 10-question document, internationally validated, and it starts, it takes a very stepwise approach to prescribing. It looks at the indications for the drug. Is it effective? It asks whether the dosage was correct, whether the directions on the prescription were clear. This is now based on the recommendation that you take the 10 most recent prescribing activities. Some people think that's maybe not the best approach, that you should, maybe broaden out the prescribing activity and review from that. But it goes through in a very logical way all of the measures that are essential to support safe practice. So it's a nice document, and I'd be interested if you're using anything different or better, maybe just let us know in the chat, please. And do keep the result of those audits of your prescribing practice and have them, whether they're scanned as an electronic file or whether you keep them in hard copy, because as I say, when hit the call again, it's very nice to have those. It's nice for you to review them and maybe have a group or medication safety committee and make a point of ensuring that you are a standing agenda item on that, be it quarterly, be it, however, but that those audits are looked at by someone other than yourself and your peer that has helped you conduct them. Now, I mentioned the standards for nurse prescribing. This is the 4th version. I think these started with 8 standards going way back to 2008 or 7 and 8. They're now up to 11, and as you see, this is just based on learning over the years. But it's they encompass everything from the clinical decision-making process, and it's always important to know that it's not a case of being a prescriber and sort of have pen will prescribe. You need, sometimes you make the decision that a prescription is not necessary at all. And I know that in certain settings, patient expectation is a lot to manage. How often do we hear of someone attending a GP surgery or an out of hours, and particularly with a child, and they'll say, well, what were they given? There is a bit of a culture, I think, among us that if you don't get a prescription when you attend the doctor and something is wrong, then you've been shortchanged. So that is point number 1. That's an important one, and that's all the way down through communicating and history taken documentation, the prescription writing itself, and their standards and codes, which I'll come to briefly soon. Prescribing for self, family, and significant others. At all points a no-no. Does it happen? I suspect it probably does. Rules around repeat prescribing in various settings, off-label and exempt. All of this is there. The guidance is there with NMBI all the way through. The separation of responsibilities in the medication management cycle. This applies very strongly where, particularly in general practice or in vaccination clinic settings, where you might potentially be the prescriber and the person administering the medication, or in this case, the vaccine. That's not banned, but you have to be doubly sure that every step is followed and that what you do there is correct and right in that situation. And I would recommend you have somebody alongside you to check and to be, another pair of eyes and ears on that. Now, the new additions recently are obviously the outside interests, so pharmaceutical companies or similar organisations. I know back to my time in general practice, they were a huge presence they called, there wasn't a week that went by that there weren't pharmaceutical companies and reps who wanted, an appointment with us. We're very keen to get our ear, very keen that even as nurses, we would be influencing prescribing, particularly around, say, respiratory drugs, diabetes, long-term conditions, all of that. And the standards also remind us that our CPD and continuing competency around prescribing is very, very important, particularly because of the pace of change within medications. And there are many resources out there, and a lot of these were covered today. The one on the left here, very much around being safe in prescribing, and just every so often stopping and checking in yourself to ensure that along that whole process, that you're thinking each time around all of these. From starting the medication, is it necessary at all? Is it the correct one? Is the dose correct? Your prescription writing, to taking the medication, adding something in, again, safety around that, reviewing them and stopping them. And sometimes some of those steps are steps that we're very poor on, and I would say certainly steps 4 and step 5. We don't often review, we don't often stop. The No Check Ask campaign, which is our own local HSE campaign, together with the Pharmacy Union and Safer Meds, is a very good one. And there are many, many resources and templates available and associated with that campaign that I think in practice we should all be encouraging our patients to use. Those are available to get. We should use them, we should have them. It's been mentioned many times already this morning that when we attend for appointments, we're now asked to bring a list of medications with us. Many hospitals and clinics are kind of ahead of that and sending, a recommended list for people to fill in, and that's a good thing. And it also, encourages us to think about the volume sometimes of medications that patients are on, the need for them, the safety of them, even to ask the question, are you taking all of these? Because sometimes, that doesn't happen. And we need to be, we're very good at, around prescribing, at giving prescriptions, but we have to be sure that patients know to come back to us if they're experiencing anything that's different or worrying for them. Our regulatory body, this is the NBI, who will be, the court in which we're judged if, in the event that something goes particularly wrong, have many frameworks in order to support safe practice. The decision-making framework on the left here is for nurse and midwife prescribing. Sure, if you're a prescriber, you will know this. I don't know how well you know it, how much you use it, but I would say print these and have them and know them. And make sure everybody around you knows them if you're prescribing. And that decision-making framework particularly supports prescribing within scope, because it's not a case of you being a prescriber and prescribing, a medication for a clinical scenario that is not within your scope, your education, your training. And also the decision scope of practice, decision-making framework on the left here that's relevant not just in prescribing but in all settings. So I'm just going to briefly touch on safety and medicines administration, because this is a huge part of the role of the nurse and midwife in any patient-facing clinical situation. And this is NBI's definition of the administration of medication. So that's to a patient or by a patient of a medicine onto or into their body that is for therapeutic, diagnostic, prophylactic or research purposes. And that onto was one that actually was a bit of a reminder to me. There's not all about swallowing tablets. There are other ways. And medicines, if you're administering them, must be either on foot of a written prescription or a medication protocol. And this is NBI's documentation again and guidance for us. And again, this is a very nice publication. It was updated in 2020. And it's only about 26 pages long, but it's lovely. And there's very nice stepwise guides in there to support us in any medications management situation, to be safe and to develop safe processes. That document very much references our 5 principles of our code of conduct, our values and standards. And then there are 7 sub-principles together with that cover everything from consent to administering within our scope, to developing our own competency, the 10 rights of medication, which I'll dwell a wee bit on in a minute, monitoring the effectiveness, which again is something that maybe in hospital situations we do. I wonder how good we are at it, outside of that, and perhaps we're better than I'm giving this credit for. And also human system factors that can lead to errors, and it reminds us too that at all times if something goes wrong, to be honest and communicate openly with the patient. So it covers all of these issues, from safe and effective use of medication. So that's the whole stepwise process down from assessing, prescribing, supplying, administering, documenting, reconciling and reviewing. And there's also another that's quite old now, but I'm sure I don't quite know if it's been updated, but there are obviously very many supports there to help us with all of that. The 10 rights, I would say very strongly that when things go wrong, one of these steps has been skipped. So do you have the right patient? Very much, and we've covered this a lot today, similar packaging, similar names, making errors, even, with insulin. Trevor mentioned Nova Norman and Nova Rapid earlier. Very, very simple to make mistakes. All of those are very, very important. I would say again, print this, have it on your desk, on your desktop, have it in your trolley if you're working in a hospital situation. Every one of those, the right person, reason, medication, route, time, dose, the right form, the right action, the right documentation, and do document. And as a patient, giving the right response to that medication. All of these are the documents that our governing body, NMBI, have produced to support us around. They're all guiding documents around just the administration of medication, not even prescribing. So they're all there. You'll find them on their website. They're actually they're in that 26-page booklet. Section 2.9 of the Nurses and Midwives Act, which is what we'd be judged on in the event that we're called to answer for our actions, outline everything from the conduct expected to us all the way down through how we function and we operate. And the alternative to using a written prescription, also recommend, maybe if you want to take a slightly deeper dive into any of this, there's very nice programs emerging and being introduced to us around human factors and the types of things that can happen when things go wrong. And also our CNMEs locally are introducing lean healthcare for us all, and I've seen the white belt in lean advertised quite a few times, which is excellent. And it's really, if you only look at the simple principles of the 5 S's about sorting, setting an order, shining, standardising and sustaining, it's a good guide to how we manage and put processes in place locally to ensure we're safe in all of this. And apologies, because I don't know if Colin's breathing for me, I'm hardly breathing for me. Apologies that was so fast and so quick, and I really hope that it met some of your needs. Thank you. Thanks, Colin.